bringing me in. Again, my name is Bob Franc. I manage the competitive intelligence effort. I've actually done this for, I think, 3 years running. Might have been 2. Historically, I've always said, okay, here's what's going on in your world, and here's what the competitors are doing. Because of what's going on out in the industry right now, I'm going to do this slightly different. I'm going to present, there's new ways of competing now. I know there's one on both ends. Half of you can't see it, the other half can't read it because my writing is crap. But you have different categories of competitors, and I'm going to talk about them by category, not by individual companies. So you have, obviously, payers, United, CVS, technology companies, Amazon, Alphabet, etc., health systems. You know, let me back up a minute. The basic client here, I know you're developing for consumers. Forget about that for a moment. As you get deeper into healthcare, that's your client, health systems. They're the ones that adopt it. They're the ones that are going to get their patients to use it, not you, me, Humana, or any other payer. So other health systems, Geisinger, the University of California, Mayo, they have the incubators, they have the digital teams, they are actually giving or selling technologies to other health systems. Retail pharmacies, Walgreens, CVS, obviously, those are the big ones. They're doing something. Then the enterprise technology companies. Some of them are known as health IT companies, EMR companies, Epic, Cerner, Allscripts, but also some of the enterprise technology adopters like AD. All of these represent your competitors as a collective mass. They're each doing different things. And I'm going to start out by saying this. I'm going to bring it up again. It's going to be slightly repetitive, but the key message is, if I'm running Baptist East, I'll use that because most of you are probably from here. If I'm running Baptist East, I'm not going to use any of Humana's technology. I don't need you. I got everybody else giving me technology or selling me technology that is directly integrated into my patient care. So you have a lot, that's the biggest thing is, because we have members going to Baptist or Norton or anywhere else, we no longer have a lock on those members as far as healthcare is concerned. And I'm going to go into that. Now, let me start here. Technically, these are two health clouds, healthcare and you guys, healthcare technology. It kind of looks more like two pigs butting heads in the sky, but I'm not very good at artistry, so that's what it's supposed to represent, because theoretically, the digital tools should seamlessly interface into healthcare, but it doesn't. What you guys do, and I don't mean you specifically, I mean digital teams, it's more like butting heads. It's more like two clouds colliding. There's a little bit of give and take. Some people adapt, some people don't use them. A little bit of spread, you build the next generation. You come in again, more people take them, other people don't. And that's what the way you've been doing it. And I'm going to show how things are changing in that area. Now, this is the competitive universe just 6 years ago. We didn't care about what, some of you, if you've been around in the digital team since then, you were doing other work, I don't know exactly what you were doing, but if you talk to the management team, if you talk to Alan, we do especially, we don't care. That's what we care about. The geographic location and what the other insurance companies are doing, meaning insurance plan. It was always set by region, by market. If United is big in Miami, I don't care because I'm running to Seattle. Now, our competitive universe today. Obviously, you know more about it than I do. This is illustrative only, and I'm probably missing somewhere on the order of 15 to 2,000 other companies. The point is, it is no longer centralized by market or geolocation. Everybody here, regardless of whether they're a startup company, usually backed by VC now, they all have nationwide access. I see a lot of a Seattle company supporting Miami, somebody in Bangor, Maine supporting San Francisco. Geography is no longer an issue. Even if it's a startup company, there are intermediaries, they get out there. The other thing I want to bring up here is, now forgive me if I offend some of you, but I'm thinking of it from an outsider's point of view. To me, you've been developing, and other digital people have too, again, I'm not singling you out. Other people, you've been developing it as a product. This app is to do this specific thing. And that's it. Give it to you, you're going to use it, happy about it, don't care. These are some of the things that you need to look at. This is a continuing care. Every tool that you make should address multiple entries. Singular entries, we're going to do it for whatever is no longer acceptable in the market. It should address as many as possible. Here's the facets of the technology. Pardon? The facets here, doesn't fit into the workflow. Again, health system is the primary customer. Even if you're developing something for the consumer, even if you're developing something for me, I'm going to go to my doctor. I'm not going to Humana or United or Aetna. And they all know that. Now, what about the workflow? What about patient engagement? Financial viability. Well, we're going to sell you this is really cheap. If I'm a limited income Medicare Advantage member, and I'm collecting about $1,700 a month for Social Security, and I'm paying $600 a month for my insurance, you telling me that $10 a month for an app will monitor disease, you know what I'm going to tell you. It's not going to. Is it integrated into the care continuum? Again, and the rest of these. You don't touch all of them, but you should be able to address almost all of them with every single thing that you do. Now, what I can tell you is almost categorically everybody else is. Everybody else, when they do their concept paper, when they do their marketing messages, bring these points up. Okay, disruptive future. This is what's occurring now. This is the big point again, enabling health systems to bypass the office. There's a lot of opportunity for them. They don't need the payers. The health systems have been waiting for the payers to cooperate with them, to work with them, to fix some of the shortcomings that they recognize. The payers have not come through. They said, that's it, I'm tired. We know value-based care is going to be here to stay. It's already too far down the path of commercialization for Trump or somebody to push it back to fee-for-service. Everybody's doing it. Payers, you have not stepped up. We're going to Amazon. We're going to Google. We're going to Epic. We're going to Allscripts. We want them to solve our problems. And that's what's going on right now. Now, well, I'm going to go over that for in a minute. This is what I already told you. The disruption to your growth, your success, is from these categories. Okay, critical common trends. Again, the first one, the key point, keeping up with current demands. They've gone and moved away from payers, and they're saying we're going to everybody else, Epic, Allscripts, the rest. Now, there's two key issues here. The first one, like I said, is I don't need your equipment. Again, it's a little bit hyperbolic, but essentially they could just say that. We're not talking to you. We have a couple of accounts that's going through that right now. But the other one that no one has addressed yet is what happens with the technology imbalance between Humana and healthcare. Now, let me give you a good illustration. Now, I'm going to use myself, it's fictional, I'm fictional too. I'm going to Baptist East. I get diagnosed with clinical depression. So, they take my blood for the lab works. They also do a gene screen. There's a lot of hospitals that do that. We don't accept them, except in oncology. There's a lot of hospitals that do that as a matter of routine, larger medical centers. So, the result of that gene screen is that the standard treatment for depression, first line, is SSRIs, like Paxil. They have determined, based on my sequence of genes, that I am totally immune to Paxil. Paxil won't work for me. So but I do respond to the newer agents. They're going to prescribe a newer agent. Well, guess what Humana's going to do? They're going to reject it. Because our formulary, which is not based on science, but based on cost and generalities, they're going to say, you must use an SSRI for 2 to 3 months first. Then you add something on top of that if it's ineffective. Then you change SSRIs. Then, 1 year later, you can go to the class that actually works. Meanwhile, my depression keeps declining. Suicide, or, you know, that's an extreme, but that's what's going to happen if we don't keep up with what's going on in general. And that's going to become more frequent as other things occur, as other things are being built, like machine learning and AI for disease detection, and more personalized medicine, which is pharmacogenomics and genomic sequencing. Now, leveraging predictive analytics, targeting patients with early stage disease, that is a huge one. There's a lot of work going on, especially at Alpha. They are aligned with more health systems than you can count, because the health systems are coming to them. They don't need anybody. They don't need to reach out to anybody. They're all coming to them. How can I detect diabetes early, even before metabolic syndrome rises? How can I discover very, very early stage onset colorectal cancer? And that's what they're working on. And they're doing it through two ways. One, personalized medicine, again, gene sequencing. But the other is using AI, machine language, and other technologies you're more familiar with, automatically pulling that data out of the EMRs and the other practice management systems, detecting it earlier just through the data. And there's, I haven't counted, but there's a lot going on in almost all diseases all around the country in this area. Pharmacy, that's outside your bailiwick, I know, but again, the trend is same or next day delivery. Now, they say, technically, you might say free delivery, but it's like Amazon Prime, you're paying a fee. But it's also full transparency. Now, if you notice, that list is comprehensive. Humana's not on it. I'm not saying we're not working on it, I don't know. But as far as public knows, we're not working on it. Personal health records. Some of you I know, some of you are looking at it. Sound like Chicken Little with the sky falling, I know. But if you're not out there with a personal health record capability within the next 3 years, you're going to be waiting behind everybody else. Now, there's a caveat. Yes, the Apple phone has personal health record capability. I don't have it. I have, I don't know, whatever that one is, i6, iPhone 6 or something. I'm not going to buy one just to have personal health record. But all the EMR companies, a lot of the health IT companies, the other ones not EMR companies, well, both of them, and a lot of startup companies are working on personal health records. So this year, every United member has the opportunity of a free personal health record. And it's going to balloon out. That is the one key thing. If that one's not a priority project here, you're going to be in trouble. Personalized medicine, I'm not going to go into that because that's in the gene sequencing. Then the competitors now prioritize Medicare. That's number one. Now, 2019 AEP, Aetna, who has been really focused on Medicare for 3 years, got 21% growth. Anthem, who has been in 2 years, got 12% growth. We got 8% growth. By actual numbers, we have a lot more because we had a lot more to start with. They had a lot fewer, so 12% and 21% growth is not as substantial as if we got that. But each year, as Anthem and Aetna have done that 2 and 3 years running, so the numbers are starting to normalize with each other. And a lot of what they're doing comes from healthcare and digital. And I will go into that. Now I'm going to go off script a bit because I took some notes from yesterday. I'm going to get down to some little specifics that deal with you guys directly. It's not here, sorry about that. If anybody wants it, I can send a list of what I'm talking about. What should you be doing right now? Okay, again, I'll put it in context. The biggest threat is the health systems no longer need Humana. Except for insurance, which is risk management. There are alternatives. I'm not going to go into them because that's beyond the scope of this discussion. So, the critical trends, what they mean for you. You should be looking at care, especially complex care first. Those are the people that need these digital tools. Not the person who's healthy, who may say, okay, how far did I run or what am I eating? But it's the people who need care management, particularly complex. Everybody else is looking at complex care first. United has attributed growth to having apps that I won't say solve, but that satisfy the complex care population. And they've been growing based on that. The next one is, and I should say too, that automatically downloads and integrates data into the electronic health record and the clinical surveillance systems. If it doesn't automatically use it, well, let me tell you, I'm not very good with technology. If you give me an app and you say I have to manually upload, manually download, manually do this, I'm not doing it. So you're going to lose a lot of people. It's no longer passive, like the Apple app that I have for walking or something. It has to be active, and it has to automatically collect data, whatever that data may be, for whatever disease you're treating. It has to act. This one isn't quite eloquent. I've got a bit of an illustration that will be more clear, and I'll say that in a minute. But it has to be able to automatically warn and alert, remember, patient, the doctor or the healthcare practitioner, the healthcare team, and dump that data into the health record for record keeping. It has to identify the trends that the member is going through. If I'm a diabetic and I have a certain time of day when my glucose goes up, it has to be able to automatically capture and warn people about that. When it's going down, same thing. If it's med adherence, it has to be able to tell me when I'm supposed to take a pill. Red pill, blue pill, whatever. Next one, it has to include data automatically from medical and OTC devices. And again, if it's not doing that, everybody else is doing it. There's a lot of work around pulling the data, like from obviously the glucose meters, the continuous glucose meters, the big one, but they're pulling it from other medical devices as well. Must have edge computing. I'm not a technology guy. You guys know a lot more about that than I do, but it has to be able, at my level, have that a little bit of the AI chip like Apple has developed, and so does the United. Machine learning with a predictive capability. Because the information has to come to me in real time. Not 2 days later, not 3 months later, but that day, that minute, that hour. And it has to be available 24/7 because I'm trying to live my life. And of course, like I said before, it has to automatically pass the data to the health team and go into the records. And it has to integrate into a virtual care strategy. Now those 6 things that I just mentioned, every payer is doing that. Every health technology company is doing that. Most of the startups are doing something like that. This one here this is a little bit more in the weeds. This is an illustration. Medical tracking app. So for med adherence. Can easily import prescription lists without manual entry. Quickly enable pill reminders. Allow user to receive relevant medical information and automatically warn patients of drug-to-drug interactions. The app is supposed to be able to see the exact medical list from all the doctors that I go to. Because if it's only pulling it from my primary care and I'm receiving 2 or 3 specialty cares, then it's worthless. It really is. Because most of the drugs from drug-to-drug interaction and the ones that are really dangerous come from the specialists from primary care. So it has to be able to capture all of that. Chris, I hope I get it back. Or I'm really going to be speaking in extemporaneously. Okay. Disease management, big trend. Automatically accessing lab results from the electronic health records. Automatically pulling the data from lifestyle, the digital apps, the IoT, and combining it and suggesting the next best action for me to take. And also with rewards and incentives. Here's the next best action for you. If you accomplish it, you will receive a $25 gift certificate at the end of that period. It said something like along those lines. Now, of course, as you probably know, there's a lot like Ondua, I guess that's how you pronounce it. They have multiple disease apps that they're developing. Primarily, they talk about diabetes because there's a lot of comorbidities that occur with diabetes common. So you've got the constellation of diseases, hypertension, high cholesterol, weight loss. It does that for everything. So instead of 6 different apps, I have one app that does 6 different things. Okay, let me continue. Am I going too fast? Boring people? I get tired of this Okay, the technology trends. Some of this is going to be repetitive, but the expansion of machine learning, that's big, because there's too much data out there. Doctors can't review it. They need AI and machine learning to detect the abnormalities and then automatically bring them to the doctor's screen when the patient is in the exam room. So it has to have, its prerequisite is you have to have access to real-time clinical data, not the claims data. That's 3 months out of date. Growth of the enterprise resource planning. That goes back to one of the comments on payers as a whole, United being the exception. We're ignoring what the health systems are asking for. The big thing they've been asking for is how do we improve our operational efficiencies? And we have not done anything in that area. So that's improving the physician pain points. Prior authorization being a big one, tiering, administrative burden, sending 400 surveys to a doctor to say, how are we doing? I know how I would respond, and I'm not exactly Mr. Diplomacy. Transformation to telehealth to a virtual care. Telemedicine is not virtual care. Telehealth is telehealth. Basically, for healthy people, really, telemedicine is more for sick people. Virtual care is an integrated technological capability of working right in the workflow. Remote monitoring would be a good example. Continuing evolution to consumer-driven. You've already heard about that. Amazon, obviously Amazon, Apple, Google, and all of them, they're already to consumers. They got a lot of that data. Now, more common focus of technology. A lot of times you'll be, I'm doing a little bit of guessing here. A lot of times you're going to be getting, let's say, engineer endpoints. This is what you need to show. I'm a doctor, I don't care. I want to know what that tool that you're giving me does to improve my patient's clinical outcome. If it's asthma, does it improve FEV? If it's AFib, does it detect and help monitor and manage irregular heartbeat? If you can't prove that, then why are you coming to me? I don't want to listen to you because that's what I want. Lowering costs for patients, medical costs, clinical costs. Through the Apple Watch, obviously the personal rewards, taking the meds, med adherence, and again, linking medical devices and OTC devices with digital apps. So basically what I'm talking about in a very simple term, conceptually, is creating an ecosystem of apps that essentially allows me through one portal take care of all. I know it's not that simple, but if you had a North Star, that should be it. And development of digital therapeutics. I'm not going into that because that's a different discussion, but as you can see right now, there's 821 clinical studies ongoing for digital therapeutics. Now, I'm going to go back a second when I talk about improvement of clinical outcomes. If you tell me it improves this clinical outcome or that clinical outcome, I'm not going to believe you. You don't have any background. You don't have any, you're not a doctor. I don't trust you. If it's been approved by the FDA, I will believe that because there's clinical data supporting the evidence that app actually works in these patients and here's what you can expect. And there's a lot of that going on. Okay, now I'm going into the categories. So now first I'm going to talk about payers, obviously the big ones that we're used to, United, etc. United builds ecosystems. They're not quite, they're semi-closed. They're not self-contained. They buy providers in geographic areas. They make deals with hospitals. And they say, we can help you improve your bottom line by alternate sites of care, which is often ASC. ASC is ambulatory service. We can build MedExpress for urgent care. We can help you shift patients from inpatient and bedtime to these places where you'll save money. Now, historically, hospitals didn't care. And I'll tell you right now, HCA, the biggest one, the CEO went public and said, I don't give a shit about value care. I'm not doing it until we're bankrupt. So it's not really, I'm making things sound simple. This is what you need to do, but in the world of healthcare, it's not all uniform. And he actually said that word too, publicly. The largest array of tools, which you have heard, the payer agnostic, CVS Aetna. This is the illustrative new front door to healthcare, which everybody, which of course Bruce has also said the same thing. We're going to provide the front door to healthcare. What they need is lower cost of care because you're going to an alternate site of care. Doesn't matter where. In this case with CVS and Aetna, they're going to go to the CVS minute clinics. Now, don't think of the minute clinics that you're used to. This is something completely different. The first concept store is being launched this month in Houston, and others will be launched this year. What it is a revised CVS store. Let me see if I have just a picture of this concept. Yeah. 20% is going to be allocated to healthcare services, meaning they're going to have a nurse or a PA. They're going to have virtual care capability. They're going to have labs right on site, so I can get my lab work done by either Quest or LabCorp. They're going to have audiologists. They're going to have whatever you call it, vision. They're going to be there. They're going to have other things as well. They're also going to restock the shelves. They're going to put durable medical equipment, OTC products. When they use hotspotting for the local area around that CVS store, they're going to see what are the most common OTC products purchased, and they're going to put those on the shelf. So a lot of the stuff like the food, we use CVS as a quick stop, really. So we go there if we don't want to go to Kroger, CVS is closer, we'll go buy whatever. They're going to downplay that because they haven't been making sales, and they're going to lose a lot of the other beauty components because Amazon has been out selling. So they're going strictly to this healthcare thing. Now, key point, they're not looking for walk-ins. They don't care. That's not their strategy. They are going to the healthcare systems and making deals with them and saying, we can manage your patients with you in between PCP visits. So if I'm only seeing my doctor once a year, I go to them whenever, or 4 times a year. I get discharged from the hospital, I'm going to be taken care of here, not at the PCP office. I will go to the PCP within 7 days after discharge. Depending upon what I was in for, I will go see the specialist or somebody within 6 months and a year. But in between that, I will be going to this clinic. Now, since 2014, CVS has set up 70 arrangements with health systems, including like Dartmouth Hitchcock, University of California Medical Systems, Johns Hopkins, a number of other ones you probably recognize, and they have not lost a single contract. Every single one has been, they love it. They make the deal with the healthcare system to do this. So that's how they're going to manage it. These are the things they're going to do. The more intense care management between the visits. They're going to integrate, they're on Epic. So everybody that's on Epic gets the same system data. Now, I say that almost tongue-in-cheek, because one Epic system does not necessarily talk to the Epic system. It never has. That's a mistaken belief, urban myth. I once saw, this was years ago, but I once saw an attempt between 3 major Epic sites to communicate with each other. It took 6 months to do. There's a lot of work still to go into that. Now imagine trying to connect Epic to Cerner. They will do readmission prevention. They're going to hold their feet to the fire for readmission prevention. Early ID and management of chronic diseases. Again, it goes back to machine learning AI, detecting diseases early, and pulling data from the EMR, so the doctor doesn't have to do it. Home or clinic site infusion. Okay. We're looking at home infusion. That's a big thing, everybody else is. Home infusion is not necessarily the right pattern to do. I'm not saying it's wrong. I'm saying for some people, like social isolation, home infusion is dangerous. If they're a hoarder, if they're a pigsty, home infusion is dangerous. You do alternate site of care. Quorum is going to set up in some of these several dozen clinics. So Quorum can do oncology, Hemodialysis, now there's a difference between dialysis and hemodialysis. Hemodialysis is better than regular dialysis. DaVita and Fresenius do hemodialysis sometimes, but now they have the new technologies, they can actually do hemodialysis at home. The other one, complex chronic disease intervention, especially CKD, chronic kidney disease. That's a big one this year. That's going to be launched, and according to one nephrologist, the guys who look at the kidney specialists, this is groundbreaking. I don't know what it is, I haven't seen it, they haven't mentioned it, but it's due to launch this year. And of course, improved med adherence, using the technologies that your peers. Anthem, not really important here, but the key thing is, we've always looked at Anthem in certain states, the 14 states are in. Anthem has now what's called the Blue Utility Network. So within Medicare, our market, and Medicaid, Anthem is making deals with the not-for-profit Blues. They're building an Optum-like company with everything there, Care More Expensivest model, digital tools, the capabilities, IngenioRx, which is the PBM, Aspire, which is the equivalent to our Health, and they're sharing them with the not-for-profit Blues. So not-for-profit Blues is primarily commercial. If they want to gain access or gain market share in Medicare and Medicaid, there's already been 7 deals made right now, all in Medicaid, because there's some of the MA stuff that's not been built yet. That's due to be launched this year or next year, I'm not sure. So they have that opportunity to just align with them. They get all that national level population health capability, and they have the not-for-profit Blues local capability, local network. So you can see, just from that, it's getting a lot more competitive for you guys. Now, don't worry about reading it. I can't read it. I uploaded it. It's just illustrative of, I took a top 175 startups. I got this from, CB Insights. Okay. Now we talk about Apple, Amazon, and Alphabet. I would talk in more detail, but again, you have time limits, so I'm just kind of touching on all of these. I do have some more details if you would like them. Obviously, for Amazon, the big one is same the next day pharmacy delivery. That's going to include DME, durable medical equipment, and medical supplies, and including OTC products. So, what's going to happen in this case, Amazon is going to have something like, what's that, Office Mac button, press a button. Yeah, they have something like that for inventory. So, and it's embedded in the workflows in the EMR. So, if I'm going to be released from, let's say, kidney surgery, the doctor only has to do is type in what durable medical equipment, what medical supplies, OTC, drugs, everything into there. Amazon will get it, and Amazon will have it waiting for me at the house when I get it. Great. Alexa, which you're probably obviously familiar with. Exam room, virtual scribe. You no longer, my doctor, probably all your doctors, are going to sit catty corner, you're my patient, I'm kind of sitting like this, keeping you out of periphery, typing as you're talking. They'll be virtual scribe now. They don't need a headset. They just need Alexa in the exam room, and they will talk their physician notes. What will happen is behind the scenes, that unstructured data will be parsed into structured data and go into the electronic medical record without interference, without them needing to have spending the money for a transcription specialist and spending the money time on their phone transcribing it themselves. So it'll be automatically be dumped. So there's one huge pain point there. Home care, making Alexa, especially for social isolation, making Alexa do multiple things. I know, they have biometric programs. They're trying to. I'm doing this off the top of my head now. I know they're looking at epilepsy. They're looking at Parkinson's. They're looking at other things, and they're developing with Alexa remote sensors that can detect early signs of that going on at home. Because I don't know if you know this, but when you're a doctor and you're treating especially older people, a lot of them, oh doctor, I got this and I got that, and they seem to go on forever. A lot of the critical things they don't talk about, and so the doctors don't know about it. Alexa can pick some of that. That's what the Amazon's doing, trying to pick up some of those things seniors don't necessarily talk about. Apple already talked about personal health records. Ecosystem, again. And again, Apple doesn't have to reach out. Everybody comes to them. And they have the research kit and care kit and all those others. Anybody trying to make an app is trying to reach out to Apple. I want to become part of your ecosystem. You know, it's just like the spider and the fly, except this is a huge web, and all the flies are coming there because there's fly food on it. And they just sit back and say, well, we can pick and choose. And they're making different types of ecosystems for different diseases. It's not just one broad. Alphabet, data storage and analytics. They're working in the back room. Again, earlier disease detection, earlier diagnosis. It's two entirely different things. Improved patient management, based on pulling data automatically from the electronic medical records, PACS, the surveillance systems, practice management systems, all of these things. Pulling all that data automatically behind the scenes and identifying automatically to the doctor when he's looking at the patient, or if there's an alert going to his desk, that Bob Frank has a problem. And here it is, so that the doctor can act on it immediately. Now, EMR companies, what are they doing? Obviously, they're trying to automatically pull data from electronic medical records. Now, originally, when the electronic medical records were developed, they were developed strictly for a transactional view and mostly around billing and administrative procedures. First EMRs came out, there was nothing clinical about that. Clinical was the first way they went to try to differentiate. But they didn't really do that good of a job. They tried, some of them did do really good clinical systems. But they forgot the original direction, and they didn't put the billing on. So it was a really, I used to work in that area. So they went the wrong way, forgot about it, or they went the right way, and they still forgot about doing the other thing. So now, they're not building new EMRs. They're not even calling themselves EMR companies. They're calling themselves technology platform companies. They're building the apps on top of the EMR that can pull the data that the doctors need automatically. So they're building this ecosystem of apps that is set around their core EMR. And they're applying, obviously, AI, machine, deep learning to pull the clinical data and practice management system. They're doing the same thing I've already talked about. Again, earlier identification, better treatment. It's both by population health and personal health. So you have a problem different than me, we would see two different readings. We're in the same cohort because we actually have the same disease constellation of diseases. We would fall under the population health. Now, most commonly to discuss with population health is public health, flu, measles and Oregon, other things like that, breakouts. And that's what hotspotting is about too, finding the areas that have intense concentrations of whatever public health hazard. And expanding capabilities to include genomic data, personalized again. That is one of the big things that's going to bend the cost curve. Most of the things I talked about helps kind of shift the cost curve. The personalized medicine, the genomic screening is going to bend the cost curve. But it's all going to be developing on top of the other, on top of the core EMR. Now, the technology-enabled MA carriers, the Oscar, Clover, Bright Health, Devoted Health, probably others, high-tech integrated software. So when I talk about that, what I mean is that their revenue cycle management, their clinical management system is all one technology, one system. Ours isn't. Ours is legacy equipment. We have, and I don't know the exact numbers, but let's say for illustrative sake, they have 4 lines of different technologies for revenue cycle, which is really business processing. They have teams that they've hired to normalize the data and move it from one room to the other. So by the time I would need data coming out of there, it's going to be 2 months because it takes time. Because they have to look at the data from one stack, normalize it, read it, see if it makes sense, put it in the other, change it to accept the technology in the other stack, and do the same thing with the other stack and the other stack. And we do that also in the claims adjudication. We are working towards building more of a cloud-based system that is totally integrated. That'll take a while. Of course, they target markets with a higher rate of MA eligibility. They have a heavy use of predictive analytics. Again, it's all in that integrated technology. Clinical finance is key to clinical because I can guarantee you, working with doctors for over 20 years, there's not a single altruistic doctor in this country. You know, Schweitzer died a long time ago. Trust me, they all want money. They all want their money. If you don't have the financial side of the clinical operations down, you're suffering because others do. I almost said everybody else, they do. Others do. Healthcare navigators. This is what's making them, and concierge medicine, this is what's making them take over in areas we can't get into because it's immediately responsive. Now, Google is on the board of Oscar, and I'm not sure if it's Clover or Brightout. They also own stock, and they sit on the boards there. So all the technology that like Viability develops goes to Oscar and goes to these companies. Walgreens. This is a new one. This is a little different. Now we have a relationship in Kansas City for some customers. And of course, the rumors immediately came about, we're going to merge with Walgreens and we're going to do all these wonderful things. That was based on the CVS Act. That's not going to happen. And as you can see just here, and I don't know that it's complete, they also have a deal with Viability, much more expansive one. All the Viability technology now goes to Walgreens for digital health tools. All the technology from Microsoft, the Azure Cloud AI and the IoT technologies, goes to Walgreens for digital management care. They're going to set up digital stores in, I don't know how many, I don't remember the number. They're piloting 12 stores this year, but they're going to find a whole bunch of, let's say over 1,000. There's going to be digital health stores. They're going to have consultants, they're going to have digital people, and they're going to sell or lease or give technology away along with the programs. So if I go into Walgreens and I want an adherence app, I can go to the digital store and get the one that suits Walgreens technology. And they do the administrative things, find care now, search for local, the clinics, urgent care, labs, vision testing, digital doctor, et cetera, et cetera. So all of that is going to be available to me if I go to Walgreens on my phone. I'm not going to go through this, but again, this should be a very high priority here. This one's a different one. I put it in because this is why United is successful quite often. This is a centralized, very high-tech command center, and if you see things on various military shows as a command center, you're in the same ballpark. They have all the greatest technology. Every piece of data from every market, from every patient goes into that command center, and it gets immediately analyzed and sent out back to the doctor. When alerts come, the alerts go to the doctor while I'm sitting in the exam room. And that's how they get the real-time care to the patients. They're not dealing with going back for an analysis at some point in the future. It's done in real time. This, I didn't really go through these. These are more to be read. I'm just going to skip over them. That's a little bit of fluff. Just some of the things here to find things. They asked 4,000 consumers of digital health. Low income and chronically ill. But first, the people who you should be making the apps for are the least likely to use them. Everybody said, yeah, we know that. Okay, yeah, I know. But it doesn't mean you should immediately go to the well, because if you're still making apps for wellness, you're not going to bend the cost curve at all, because they're not going to the doctor, except maybe for a physical, possibly a drug or something if they get sick or something catastrophic. Other than that, the people who need it the most are the ones who have complex chronic issues. One of the problems is, well, we want to sell them. Again, it goes back to the earlier argument. If I'm making 1,800, I know I didn't say the same amount before. If I'm making 1,750 and Social Security, and I have 8,000 in the bank, and you say $10 a month, I can take care of my diabetes, so be monitored by a doctor. Well, it's still not going to happen. It has to be integrated in, and it has to be free in some way, shape, or form. Now, it can be amortized somewhere else. It can be baked into the contract with the health system. You have a lot of latitude. It doesn't have to go to the patient. Most of the people don't know the tools exist. Well, we tell people. No, we don't. We don't tell people anything. You don't know what goes on. And even if you did, they may not remember. Oh, we'll send a direct mailing. We'll tell them in January that we have this. And I'm supposed to remember in September. Not going to happen. We're not telling them. We're not at the medical fairs, the community events that these people attend. That these people get looked at for free. That these people get their tools they need for free. We're not there. United is, so is Aetna, so is Anthem, so are a lot of other carriers. That's where the selling point is. Now, there's more to it than just selling it, because as we know, especially those who have been around with us for a while, and all those wellness programs we have 50,000 people using it. No, you auto assign that 37,000 people from Humana on it, nobody's using it. It's one thing to get them on, it's another to get them to use it. That's why the doctor has to be on. That's why the health system has to be on. Because the first patient's not going to listen to you. Again, you guys are digital experts, you're not a doctor. Even if you were a doctor, you're from Humana, therefore you have an ulterior motive. I'm going to listen to my doctor. My doctor's not going to listen to you either. Because you're from Humana, you have an ulterior motive. My doctor will listen to the governance board of that disease. That's why I'm saying the health system is the core customer. Because they are the ones that make the decisions. They are the ones that tell their doctors what they're going to use, when they're going to use it, how they're going to use it. Within limits, doctors will make that final determination, but they're going to provide general guidelines. And again, down the next, the other one is empowering patients. The one thing we tend to do, so do others, is we tell them what to do, and we figure that's engaging them. A lot of doctors do that. My doctor doesn't so much, but I don't listen to it anyway. The specialists say, this is what you're going to do. And they consider that the adherence to a care plan. That's their care plan, them telling me what to do. We're not empowering members. We're not getting them involved in the decision making. We're not explaining why you're doing it. Take that pill. Why? Let's lower your cholesterol. Okay. What do you mean? You know, and they start going into some medical diagnosis that the patient doesn't understand anything. They don't, most of the doctors, I don't know if I have any here, I don't think so. Most of the doctors do, there was a study among PCPs and specialists. Most of the doctors felt that patient engagement was instructions. They're telling me what to do. It's not empowering the patient. And that's where you also have an opportunity to change things. Is you work with a doctor and say, no, that's not it. You have to get them convinced that they need to do that because it's in their best interest. And here's some of the ways you do that. And of course, as much can be done automatically as possible is the way to go. Because take it from me, who can barely use my computer, if you tell me I got this wonderful tool that will help me with whatever diseases I have, I'm not using it. If I've got to start inputting data, trying to figure out what it means, when do I download it? When do I give it to my doctor? What do I do with it? Well, send it to us. We'll do something with it. Right. My doctor doesn't know anything about that. It has to go to the health system. It has to be done automatically. The technology is there, I know. And it has to be personalized. That one I didn't remember. If the four of us right here had the same constellation of diseases, our screenshot of whatever we're being managed should show 4 different things. Because we're at different stages, we have different lifestyles, we do different things. I may be a couch potato, I may be a slug and just watch TV. You may be out running every day. You may be out nature hiking, climbing, and you may be a big swimmer. And I'm just saying, that's 4 entirely different scenarios. And
and it needs to be done in that manner. Now, I'm not telling you how to do it because I have no clue. I'm just telling you what the others are doing. And this is common. I'm not saying that one or two that are doing this. I'm saying that among the consensus of everybody I presented here in whole, this is the general trend of what's going on. Are there any questions?
Yep. So when you say data going back to the health system and then cloud integration, who are we talking about in that scenario? Like who owns the hardware that actually pulls this data in?
The hardware, well, are we talking about the hardware in the hospital is going to be owned by, you can make an argument either way, depends upon the contract. It's either owned by the health system or it's owned by Epic, Cerner, etc. The digital apps on front hasn't really been clarified to, I don't know who owns it. The thing is, if Humana wants to be, I better not say that. If Humana wants to be focused enough to own the data, you're wrong. Because you need to share all the data. The thing that works, all the health systems have said, the reasons why I go with United, Aetna, etc., they share all data. It's our data. Not your data or your data, it's our data. So it's not so much who owns it, who uses it. And us saying we own it is like two 10-year-olds trying to own the whole ball and say it's mine. It isn't. It's actually the patient's. And that's the point of the whole patient health record.
Well, I guess like on that point, like whoever, I guess, whatever entity is pulling that in and using it, is there risk there for repatterning, you know, to benefit their own outcomes? So when
Of course.
Like, and I'm saying the data breaches are happening. Even the ACA portal, there was a data breach happening.
A lot of the stuff that's being done right now is being done through AWS. Trust me.
Yeah, exactly.
Amazon gets their crap. They're not doing it for an altruistic. Now, the big problem is when Amazon, Google, and Apple develop these technologies, they can undercut us easily because they flat out said, I'm not looking for a profit here. I've got other businesses I can pull money from. So they don't need that margin. We do. So they're all immediately going to undercut. They're going to have better technology, more consumer focus, and undercut by price. Kind of gives you an issue there. But I don't know what the level of collaboration is. You know. Now, they do have consultants. I don't know how it works installing AWS or any of the others. But like United, they have a whole big team of very good consultants who help you build it, deploy it, use it. And that's another thing we need. That's the skill missing.
So part of kind of tailoring the health, your care plan is understanding the social determinants of health
Correct.
impacting
Yes.
you. So aside from building in sort of screenings or connecting to a community resource directory, is anyone using technology to address those
Yes.
social
I'll
needs?
tell you this right now. Community resource directories and some of those other connectivities is about 2 steps from worthless. Because you're still relying on somebody to manually go through it and identify it. Now, United has taken the step. They put ICD-10 codes. They work with CMS. They developed ICD-10 codes for certain specific SDOH metrics. So that way there's a systematic way of tracking it. They have experts in the field, in the markets, who know the community service organizations. The technology I've talked about in clinical applies to SDOH as well. It will automatically detect which service is ideal for which person. If it's not done, you're at the cusp, really. If it's not done technologically, it's inefficient, it's not going to work, it's not. You guys can actually make that happen. Now, I know you take orders from above, they'll tell you what to make, but these are the things that are going on that can change how it's done. And that's what you need to bring up. So, what about this? Any other question? Yes.
So I'm just curious if Walgreens and CVS will stop selling alcohol and cigarettes and candy and other things.
That's always
That's
a political move more than anything else. That's not a launch.
I mean, it's just ironic to me every time I go in and there's
Yeah.
They're selling and probably making a lot of money on those kinds of.
Not as much
products.
as they used to because of Amazon and everywhere else. Now, I will tell you, probably with reasonable confidence, they are not going to get rid of candy. Everybody's taking kids in there. And that's why they put the candy up front, with the kids sitting in the street.
And that's why we have obesity and diabetes.
Yeah.
studies. I mean, it's just, it's ridiculous.
The cigarettes and alcohol will depend on the zip code. And that'll be, again, an internal political will.
Well, and then not just retail, but like for politicians and nation states, I feel like this data, security is not a concern. Or like we're not, like I know everybody owns it, it's there for like clinical research, and building models and driving better outcomes, but.
Well, I did list under the one facet, cybersecurity, I think.
Yeah.
I don't know what's going on in that area, I couldn't even begin to tell you.
Sure.
Obviously, PHI is a sensitive subject. There's two types of data that's going on in everything I talked about. There's the personal data, which goes with me and you. And that has PHI and it has all the privacy issues, cybersecurity, hacking, and everything else like that. Then there's the de-identified data, like the VA 10 million man or whatever that is program. That's all de-identified. So they're looking at, like I'm a veteran, I'm in part of the program. They take my blood and they're looking, they have certain diseases and they're going to identify which genes are active, which proteins are being expressed, and everything else. But they don't know it's Bob Frank, they don't know I live in Louisville, they will know, obviously they'll know I'm male because I have to identify that. They'll know I'm Caucasian because there are ethnic genetic differences. But outside of that, they won't have any information. Now Amazon right now claims with Amazon Web, they don't have access to that data. That's why, in this case, I'm going to retract what I said earlier. Amazon and Google verily are reaching out to the healthcare system. We will develop this technology with you as long as we have access to patient records. And all the health systems are buying off on it because it actually helps them improve their bottom line. What happens after that's built, I don't know. More than likely, he's going to sit in one of those barges that are sitting outside in the harbor. Or I heard somewhere someone was going to start building satellites so that they didn't have to worry about taxes. Now, all that is all hypothetical farther down, but, you know, let's face it, Amazon, Google, they're in business to make money. They're going to lose money in healthcare first because they're going to undercut what's going on. They don't care, they got it from other areas, but it will eventually normalize out and they will start making money somehow. How?